Thank you again, Dr. Khanna. Yeah, the situation here is not good. We have a high number, and it's increasing. We have our ICU units are with full length, but we're going, and there are no people yet left without treatment. That's a good thing. But our mayor here in my hometown, he yesterday we are in lockdown. Only physicians, supermarkets, gas stations, all those things are allowed. But anyway, I think the situation is almost the same at the US. But it's my great pleasure to be here again. So we are going to have a talk regarding stem cell therapy in CLI patients. That's a very good topic that I am very grateful to share with you. As we all know, the chronic lymph-threatening ischemia is the significant ischemia that impairs wound healing and increases not only amputation risk, but also death risk. Once we have almost 25% of mortality at 1 year, and a major amputation rate of 25 to 40% at 1 year, depends on the subgroup you are studying. And also this new concept of chronic lymph-threatening ischemia also comprises diabetic foot patients. So there is a huge gap yet to treat CLI patients. And our current approach is through debridement, the management of infection, offloading, and of course, in our case, revascularization. Our aim is to improve coagulation in the right vessels, not in the wrong ones, to modulate inflammations, to promote cell migration and proliferation in order to have the wound healing. But infection, ischemia, neuropathy, and of course the metabolic disorders prevents that. So we have yet a huge road to go through to improve our treatment in such patients that have yet, despite our current technology of revascularizations, we have a huge gap because there are many people who lost their limbs and who lose their limbs and yet dies. So this new approach through cell therapy, it aims angiogenesis through cytokine secretion. Of course, our intention is to promote cell recruitment and immunomodulation in order to promote angiogenesis. Angiogenesis is the basis of our cell treatment. The cell itself do not act transforming into vessels, but instead it promotes cytokines secretion, all kinds of cytokines, in order to better promote the wound healing. That's the base of our cell treatment. Previous to our project, our group performed a meta-analysis on the treatment of diabetic foot ulcers with this cell treatment. And what we found was that stem cell treatment was safe and helps diabetic foot ulcer healing without major risks. However, we still have many questions. What type and origin of stem cell is best? Because when you talk about stem cells, all we think that is we are referring to embryonic stem cells. That's not the case. The major game changer was that we found that in adults have stem cells yet. Not only the embryonic, we don't have, not only the fetus, but the adults have stem cells. So, of course, in a very small number of cells, not like the embryo. But these stem cells can have the ability to differentiate in any kind of cells. That was the game changer. This is a major knowledge and technology that we're able to achieve. So, what's the best route of administration? And it's good in association with revascularization. So we have those doubts, and we went through another a broader comprehensive review, our group. So what we found in the literature, the types of stem cells were embryonic, of course, not human. So it's not allowed, I think, anywhere in the world to use embryonic human cells. So most of us use adult or the induced pluripotent. With some cytokines, we can induce cells, or we can program its genes to differentiate into the kind of cells we want. And the sources of adult cells are bone marrow, peripheral blood, adipose tissue, and umbilical cord. Of course, in literature, most of the research is performed by the bone marrow cells. And regarding administration route, we have local and systemic. Systemic, you mean maybe intravenous or intraarterial, but most of literature use local administration, just as we. And regarding the cells, of course, most is autologous because you prevent immunologic issues, ethical issues. And in association with revascularization, we have a few studies that shows us ABI improvement, angiogenesis, better perfusion, better wound healing, lower recurrence of stenosis, and a longer amputation-free survival. But that's yet experimental. Now we are here in our project that we call the Limb Rescue Project, just for the patients unfit to revascularization. And of course, we use adult stem cells. We use adipose cells. We go for local administration, and of course, it's autologous. So what's our intention? What's the aim? Is to use the stromal vascular fraction that is present in the adipose tissue for the treatment of patients with chronic limb-threatening ischemia that there is no possibility of revascularization. That's an experimental project. It's a phase 1/2 trial to assess safety and efficacy of this stromal vascular fraction of the adipose tissue. Our primary outcomes are to look for mortality, amputation, and wound healing rates. And secondary outcomes is to document neovascularization and the cell counting. What we do, we perform a lipoaspiration, of course, for patients that do not have any other possibility of revascularization. We intend to go for 10 patients. We are now with 4, actually only 3 have finished, but the 4 is ongoing. The fourth is ongoing. And that's very difficult because nowadays with our technology, our technique to revascularize people, it's very improved. So people without any other option of revascularization is, in this kind of patients, rare. So that's an issue for enrolling patients. So we perform the lipoaspiration, and then through a long process that takes 2 hours by filtering, washing, centrifuging, and again and again and again, we are able to isolate the stromal vascular fraction of that tissue, and then we perform an intramuscular injection throughout the trajectory of the posterior tibial artery, and a follow-up for up to 2 months. So that's the, here we are performing the procedure, washing, centrifuging, and we aim to have only a small portion. So if we have around 200 millimeter of lipoaspiration, we are able to inject the stromal vascular fraction of about 25, 30 milliliters in the patient. There are some advantages in this project, because adipose tissue is very disposable. We have no rejection, it's autologous, and we have no ethical conflict. Furthermore, it's a minimally invasive procedure. We perform this lipoaspiration under local anesthesia. And the isolation of the stromal vascular fraction is very cheap because we don't use cell culture, we don't use enzymes, so it's very cheap. It's good for our reality here in Brazil. However, we have a lower cell count, and if inadvertently inject intra-arterial, it may cause thrombosis. But nowadays, we are intended to go through 2 more branches, which is to associate with revascularization, to see if it improves the limb salvage, and directly on wounds. So, in conclusion, stem cell results in cytokines production, leading to angiogenesis, immunomodulation, and promoting wound healing. Our current evidence is that this cell therapy seems to have good results in human patients. Of course, adult autologous stem cells is the most commonly used stem cell throughout the world because of ethical and immunological issues. But there is no consensus regarding the optimal type, origin, and delivery route, but its efficacy remains to be determined. I must stress here that it's yet an experimental treatment. We are not able to offer this kind of treatment for every patient. We are offering just for this project, this research project. Thank you, Dr. Khanna, for inviting me again for this great meeting. Let's stay fighting the pandemics. So I'm at your disposal for any questions, for any further questions. Thank you very much.
Thank you very much for Dr. Tulio. It was wonderful as usual. And yes, we are all on front line fighting COVID as well. So let's go on to the next one, which is my talk about critical limb ischemia. And I believe I need to be cutting it short because we have to be on time. We have a lecture by Dr. Frank Wheat in the next to next session. And then we also have a Nobel laureate, Dr. Farid Murad, speaking from 8 to 9. So we have to be sticking to our time. So, and then after me would be Dr. Wangnu, who is going to be speaking about demystifying diabetic foot. Let me just share my slides.